Hello, everyone, and welcome to the launch of our very first adult AML chapter event brought to you by the HealthTree Community for AML program. My name is Katie Braswell, and I'm the HealthTree for AML Community Director. I'm so thrilled to see so many of you have joined us today for this exciting event and am extremely grateful for your support in building this adult AML community. I'd like to let you all know that today's session will be recorded, and the recording along with the slides will be sent to all registrants within 48 hours after the event has concluded. I'm going to quickly walk you through some important Zoom features just in case you are new to using the Zoom platform. We would love for you all to keep your cameras on if you feel comfortable. It helps us to feel more like we are in a group talking to one another, but if you're not comfortable being recorded or keeping your camera on, we completely understand that as well. If you hover over the bottom of your screen, you will see a line of icons pop up. To turn on your video, you will press the Start Video button and press it again in order to turn your video off. Each of your microphones should be muted and will be kept off by our team throughout most of the event. During the question and answer session at the end, if you would like to verbally ask a question, we will prompt you to unmute yourself at that time. If you have any questions for Dr. Stein throughout his presentation or any concerns or comments during the event, please type them in the chat and my team is standing by to read them and get your questions answered. To send a message, hover over the bottom of your screen again and you will see a chat button. After clicking here, the chat box will appear on the right-hand side of your screen. Here you can type in your questions and comments. And lastly, if you would prefer to verbally ask your question during the Q&A at the end, you will again hover at the bottom of your screen and click the participants button. A list of participants will appear on your right and you will see a button that says raise hand. We will review this again once we get to our Q&A period. And with that, let's get started with today's event. First, I'd like to thank our sponsors without whom this event would not be possible: Bristol Myers Squibb, Amgen, Genentech, and AbbVie. The topic of our event today is titled The Power of Personalized Medicine for Your AML. And now I'll briefly take you through the event agenda. Today we are joined by both Jenny Ahlstrom and Dr. Stein. As this is our very first adult AML chapter event, I have invited Jenny, who is the founder of the HealthTree Foundation, to give us a brief introduction. I will introduce her and she will speak to us for a few minutes about the foundation and provide a little background information on our programs and what you can expect from us in the near future. I will then introduce Dr. Stein and he will provide his presentation on personalized medicine for AML. After the presentation, we will open it up for your questions and comments. So with that, let me introduce Jenny Ahlstrom, who is the founder and president of the HealthTree Foundation. Jenny experienced the passing of her brother-in-law from AML in 2005 and then received her own blood cancer diagnosis of multiple myeloma in 2011. These events led her to patient advocacy and the launch of the HealthTree Foundation in 2013, which strives to remove barriers to a cure. Her goal with the HealthTree Foundation is to find a way to cure herself and others with blood cancer. She wants patients to become well-educated self-advocates so they can participate more fully in their treatment decisions and live longer, higher quality lives. She believes that in order to make faster progress in finding a cure for all, patients need to be involved in clinical studies in more meaningful ways. It is her hope that HealthTree will become a resource not just for patients, but for researchers as well. Not only is Jenny amazing at leading the foundation, she is also an amazing person. She is an honor to work for, and I'm so excited for you to get to hear from her today. And with that, Jenny, I'll let you take it away.
Okay, well, thank you so much. And we're just so excited that you're here. I'm going to share my screen a little bit, but just a little background. My brother-in-law, like Katie said, my brother-in-law, David, was diagnosed with AML. And I think we didn't have any idea what should happen when he was diagnosed. AML is different, significantly different than multiple myeloma, just in the sense of urgency. You need more information in faster ways. But it's because of David that we ended up building the foundation, and not just because of my diagnosis. He was about halfway, he was 6 months into his care, and there was really nothing else that they could do for him, and he was in acute respiratory distress. And my husband ended up suggesting that the doctors use Mylotarg for him, which was not approved for his disease at the time. And because he did that, he lived another 6 months, and we just kind of thought, his experience was lost to every other AML patient. both at Huntsman Cancer Institute, where he was being treated, and everything else. So everything that we've done in terms of the foundation is for that reason. So I will share my screen. And just give you a little bit more background. Can you see it okay? So we have our vision is to improve patient outcomes for every patient at their stage of their journey from the time they're diagnosed to the time that they're potentially cured. We have a patient first approach because we are patients ourselves. We totally understand what you're going through and how it's affecting your life. And we've done this through a lot of new technology tools. So these are some of the community programs that we have, and we believe that patients together can really, we can provide support services for patients that help educate you, help you navigate, but help you find clinical trials, help you learn more through HealthTree University, help you learn from experts like today. But then together as a community, we can share our experience and do something else. We've done this on the myeloma side over the last 8 years. It's been highly successful. We now have a data portal with patients where they're sharing their myeloma stories, and we have over 9,600 patients doing that. They get benefits by participating, like finding treatment options, finding clinical trials, and then we can help the researchers at the same time. So we believe finding a cure is this community thing, and that myeloma and patients that have AML are and myeloma are kind of responsible. It's not fair that we have these diseases that are terminal and scary, but there's a lot that we can do as patients about this. And it's not advancing. So I think for those of you who were, here we go. This is our team. Just so you're aware, we have a large team as part of our foundation. And as you may have seen on the intro video, we have AML news. We have AML events like this one. We have podcasts with experts. Katie's done 3 so far. We will have live and virtual meetings, both. We're beginning an AML curriculum. So if someone gets diagnosed with AML, a family member or you as a patient, you can go through it and quickly. I think there's urgency around AML, and you can go through this quickly. And then, like Katie mentioned, we'll have a clinical trial finder so you can find different treatment options in a faster way. And that's the portal that I talked about is what we'll end up building, that we have built in the myeloma space, and we'll build it for AML too. You'll be able to find your genetic twins, which will be helpful for you. You can find clinical trials. You'll be able to see side effect solutions that are common for either the disease itself or for the drugs that you're on, and see that kind of in a data-based way. And one of the most important things you can do is participate in surveys and studies with academic investigators. So if Dr. Stein wants to run a survey in the platform, he could run a survey and we could all respond to his questions, and it helps his research be accomplished faster from real patients. So you'll also be able to track your lab values and keep an eye on those so you can become more educated about your disease. One of the new features that we'll also be adding is video journaling. We'll be adding that next year, and we can learn from each other's stories, which is really, really important. So that's what I wanted to share, and I'll let Katie take it from here.
Thank you, Jenny. That was a great overview of what we're doing and what's to come. I'm so excited to get all these programs up and running and available to everybody. So thank you for being here. Let me go back to my presentation here. Okay, so with that, let me introduce our speaker today, Dr. Stein, who is an assistant attending physician, clinical investigator, and director of the Program for Drug Development in Leukemia on the Leukemia Service at Memorial Sloan Kettering Cancer Center. He conducts phase 1 clinical trials of compounds that target the genetic and epigenetic basis of myeloid cancers Dr. Stein led the clinical studies of the IDH2 inhibitor enicidimab and the IDH1 inhibitor ivosidenib in patients with relapsed and refractory AML that led to their FDA approvals in 2017 and 2018. His current research focuses on explaining mechanisms of resistance to IDH inhibitors and the use of Menin inhibitors in patients with MLL rearranged acute leukemia. His work has been published in many prestigious journals. I'm sure you can all gather from his bio that Dr. Stein is a wealth of knowledge, and we are bound to learn so much from him today. His experiences leading the IDH1 and IDH2 inhibitor trials are a testament to how perfect he is to be talking with us about personalized medicine for AML today. Thank you so much, Dr. Stein, for being here and sharing your knowledge with us on this topic. And with that, I'll let you go ahead and get started.
Thank you so much. And Jenny, thank you so much for telling us about this program. I have to say that this is really extremely impressive and something that I am very excited about. So let me just see if I can get my screen to share. Okay. Can you guys all see my screen okay?
Looks good.
Okay, great. So you can see I'm in New York City. That's the Upper East Side is right behind me. And you can still see it?
Dr. Stein, if you could, we can see it. If you could make it full screen, that would be best.
I think it is whole screen on my end. Let me see what I can do here. 1 second.
I just put it in slide share, like the presenter's mode, or.
Better?
There we
you
go.
Perfect.
Okay, sorry about that. So what there aren't very many good things about COVID, but one of the only good things I've noticed in my professional life about COVID is that it's actually allowed me to reach patients across the country outside of New York that I never would have been able to reach before, and that's both through programs like this, which I really enjoy doing, and also we're now able in many states to do telemedicine visits with patients. And that really sort of expands the reach of not just me, but also really all leukemia experts around the country, where even if you're in a state far away, you can sometimes visit with someone who is who might be farther away from you than you normally would be able to get to. So we're going to talk about now the power of personalized medicine to treat acute myeloid leukemia. And really, to understand acute myeloid leukemia, you kind of have to understand what normal bone marrows are supposed to do. So these are a lot of circles here. All of these circles represent cells in your bone marrow. And if you look at the far left-hand side, this is sort of what a normal bone marrow is supposed to do, is on the far left-hand side, you see this thing called a pluripotent stem cell. And essentially what that means is that there is a baby blood cell that starts maturing, turns into what's called a myeloid stem cell. And then if you follow all of these cells all the way to the right, what you'll see is that what ends up being the final product of all of this is either erythrocytes, which are red cells, platelets, which are platelets, or neutrophils, or other kinds of white cells. So what is the primary problem in acute myeloid leukemia? Well, the primary problem is this. So what happens when you have acute myeloid leukemia, and the fundamental issue is that the cells cannot mature past this immature stage of development called blasts. They are stuck in this blast phase of development. And those blasts, as those of you who have loved ones or may have AML yourself know, those accumulate within your bone marrow, and those keep the normal healthy cells from developing and being born. And the goal of all of our therapies is to eradicate these blasts and restore the normal operation of a patient's bone marrow itself. This is what a bone marrow biopsy looks like from my point of view. The patient's obviously not seeing what I'm seeing. But what we do is we take a needle and we put it into the posterior iliac crest or into someone's hip. And we aspirate a little bit of bone marrow fluid. And on the right-hand side, what you can see is actually the photomicrograph of the blast cells in the bone marrow of a patient of mine who gave permission for me to show you this slide. What you'll notice is that all of the cells kind of look the same. So they're all sort of big. They're bigger than the little red cells that you can see that are floating around. And they're all kind of just like one another. And those are the blast cells. So those are the cells you don't want to see. Those are the cells that are cloning themselves and causing all of the issues. Now, AML is a rare disease. As you might know, AML occurs in about 20,000 patients per year in the United States, and it's estimated to occur in 20,000 patients per year in the United States in 2021. However, as the population of the United States is aging, the absolute numbers of patients with acute myeloid leukemia is increasing. So even 10 years ago, there were about 16,000 cases of AML per year in the United States. Now, as I just said, there are about 20,000 cases per year in the United States. And that number is expected to increase again as the population ages. You know, just to compare this to more common cancers, like for breast cancer, there are about 200,000 cases per year in the United States. So this is about a tenth of the kinds of large cancers that are more common in the population. The median age of diagnosis of AML is 68 years old. So we certainly see younger patients, but in general, it is a disease of aging. And the incidence rises, as I said before, as the population continues to age. This is a slide from a long time ago, and that's why I'm showing you this slide. This is a slide now from about 10 years ago, showing you how, if you look at the patients younger than age 60, how the improvements in the treatment of AML improved between 1970 and 1979, when unfortunately we were able to cure very few people, up to about 10 years ago, when we were able to cure many more people. What's really interesting about this slide is that the improvements in the outcomes of patients in AML up until 2009 really had to do with two different things. One of the things was that our antibiotics got better. Specifically, our antifungal drugs became much better. And patients often with AML had trouble with fungal infections, but now, or up until 2009, we had antifungal drugs that worked and were introduced that worked exceptionally well. In addition, this is when allogeneic stem cell transplants or bone marrow transplants really started taking off. And as the decades have rolled on, our ability to transplant older patients and patients that might have other medical conditions and finding matches for all of our patients have really been unsurpassed. So this takes us till about 2009. And also what takes us until about 2009 is how we thought about the different kinds of AML. So AML isn't just one disease. AML is a bunch of different diseases where you have the same problem I mentioned earlier in the slide, that is a block in the ability of the myeloblast to mature into healthy, normal cells. And what pathologists used to do is they used to look under the microscope and group AML patients into one of these 7 groups, which we called M0 to M7. But with the revolution in genetics, one of the other things, and now the next slide I'm going to show you may scare you a little bit, because it shows you just how complex AML has become. So, you know, reading all of this is not important because that's not the point of this slide. The point of this slide is to show you that there are many different ways that a bone marrow can go wrong and lead to a diagnosis of acute myeloid leukemia. There are a variety of different genetic mutations that can occur in a bone marrow as it ages, as it gets older, that can lead to the development of AML. And you may have seen, for those of you who may be diagnosed with AML, you'll see these pathology reports where they'll talk about the genetic mutations that are in your bone marrow. And no two patients, or few two patients, have exactly the same genetic mutations. And what this tells you is that the way we had to treat AML previously, which I'm going to show you on the next couple of slides, where all patients really got the same treatment, might not be the best way to treat the disease. Because if there are all of these different mutations, that can lead to the development of AML, we need to find not only a general approach, but also targeted approaches that can personally and very carefully treat the underlying molecular gene mutations that are leading to AML in any one particular patient, in each particular patient. So when we look at these mutations and when a patient is initially diagnosed, we stratify patients into what's called favorable, intermediate, and adverse risk disease. Whether a person is defined as favorable, intermediate, or adverse risk is completely defined by this slide I showed you here. That is, what are the genetic mutations that the patient might have? The good news is that in 2021, all of these different categories of acute myeloid leukemia are treatable, and all of these different categories of acute myeloid leukemia are potentially curable. In addition, when we give therapy for AML, we want to do two different things. So what is the point of the therapy for acute myeloid leukemia? The point of the therapy is to make a patient's blood counts normal again, because that is why patients have complications from their leukemia. How do we make a patient's blood counts normal again? We give therapy that lowers the number of those blasts to less than 5% in the bone marrow. And then we also give therapy that by lowering the blast to less than 5%, that allows the bone marrow to recover, to produce normal blood cells so that a patient doesn't end up with the infectious complications that come from having AML. And from a quality of life perspective, doesn't need to go back and forth to the hospital or to the infusion center all the time to get blood and platelet transfusions. So here are the paradigms that we both had for treating newly diagnosed AML and that we now have in 2021. I'm going to show you three different things here. Up until about 7 years ago, this is all we had. On the left-hand side, you can see that for younger patients who did not have other medical problems, we used to give what was called intensive induction chemotherapy with 7 days of cytarabine and 3 days of daunorubicin. There are slight variations on this that are done regionally. In Texas, they do stuff a little bit differently. At Johns Hopkins, they do stuff a little bit differently. But in general, they give intensive induction chemotherapy. For those patients who could not tolerate the side effects of intensive induction chemotherapy, on the right-hand side, you can see the patients were given what are called HMAs. That stands for hypomethylating agents, drugs like Vidaza and Dacogen, or low-dose cytarabine. And finally, and this is sort of the most unfortunate part of all AML, is that there were a large group of patients who were not offered any treatment at all. They were offered blood transfusions and platelet transfusions and prophylactic antibiotics, but it was thought that there was no active treatment that might help them with their disease. Really, in the past 10 years, there have now been an explosion of drug approvals for acute myeloid leukemia. I'm going to list some of them here, and we're going to go through them. One of them is variations on our intensive induction with 7+3. One is 7+3 with the drug called midastorin. Another is 7+3 with the drug called gemtuzumab or Mylotarg. And a third is a liposomal formulation of 7+3 called CPX351. For those patients who might be a little bit older, we now have something that's extremely exciting, which is the combination of hypomethylating agents with a drug called Venetoclax. And finally, in patients with relapsed and refractory acute myeloid leukemia, we now have 3 targeted therapies that are approved: the IDH1 inhibitor ivosidenib, the IDH2 inhibitor enasidenib, and a FLT3 inhibitor called gilteritinib. Again, all of these different treatments are really trying to get at the specific molecular genetic alterations that are causing the disease, some of them in combination with more general chemotherapy, and some of them given as single agents and alone. Okay, this is a leukemia cell, a schematic of a leukemia cell. What it's showing you is really the different mechanisms that we have to target the leukemic blast to try to get that leukemic blast to die. What's highlighted in yellow is some of the different ways that we try to target the leukemic blast. So the first twist is the thing that Jenny talked about earlier when she was talking about her family member. And that is a drug called gemtuzumab osigomycin. The trade name is Mylotarg because it targets myeloid cells. It was a stroke of brilliance by the marketing department at whatever company developed that drug. And this is a drug that targets something that sits on the surface of the leukemia cell. And that is something called CD33. Gemtuzumab is a drug that targets CD33 and has a little bit of chemotherapy on it, so that what happens is that the drug binds to CD33, drags the leukemia into that leukemia, drags the chemotherapy into that leukemia cell and causes the leukemia cell to die. So it is a targeted therapy for patients with CD33 positive leukemia, that is AML, that has CD33 on it. So why do we do this? We do this based on these survival curves. I'm going to show you a lot of survival curves. So for those of you who have not seen survival curves, the way you read these things is as follows. On the bottom, this is time going from 0 until 45 months here. And on the top is the number of patients who have survived. And what you can see is that the patients who receive the Mylotarg in combination with intensive chemotherapy on the top curve here seem to do much better than the patients who don't receive the Mylotarg when they are CD33 positive. There are caveats to all of these rules, by the way, so you shouldn't take this as like sort of the gospel. But in general, CD33, if you've got CD33, adding gemtuzumab to intensive chemotherapy leads to better outcomes than just giving intensive chemotherapy with 7+3 alone. The second twist on intensive induction is with a drug called midastorin. So midastorin is a drug, an oral medication that targets a mutation called FLT3 or FLT3. When patients have FLT3 mutations, what we used to do is we used to give them just 7+3 alone. But what we know now, again, looking at survival curves down here, is that if you give intensive induction chemotherapy to a patient with a FLT3 mutation, if you give them that intensive induction with the FLT3 blocker, the FLT3 inhibitor midastorin, those patients do better than the patients who just get the standard old chemotherapy with 7+3. So we've now talked about two personalized treatments we can give. We can give gemtuzumab in combination with chemotherapy to patients who have CD33 on their cells. We can give midastorin in combination with chemotherapy to patients who have FLT3 mutations. Are there any other things that we can do? Well, there are some patients with acute myeloid leukemia that they didn't get their acute myeloid leukemia because they were getting older. They got their acute myeloid leukemia because they either had received a different chemotherapy for a solid tumor, and that different chemotherapy caused DNA damage that led them to develop leukemia, or they had a disease called myelodysplastic syndrome, or MDS, that turned into acute myeloid leukemia. So in the first case, a common scenario is that there are women who sometimes get chemotherapy as part of the treatment for their breast cancer, and about 2 to 3% of women who get a specific kind of chemotherapy for their breast cancer years later may go on to develop leukemia as a result of that chemotherapy. And that is called therapy-related acute myeloid leukemia. And in patients who've had a prior MDS, a prior myelodysplastic syndrome, who go on to develop AML or acute myeloid leukemia, those patients have what's called secondary AML. So there is now a drug, this liposomal formulation of 7+3, that is used specifically for patients with secondary acute myeloid leukemia and therapy-related acute myeloid leukemia. So what is liposomal 7+3? What the hell does that mean? So what's a liposome? So a liposome is best explained. I've thought about this for a long time about how to explain what a liposome is. A liposome is, think of it as a soap bubble, okay? And instead of the chemotherapy that we normally give, where it sort of drips into your vein and goes like kind of all over your body, this is chemotherapy. This is 7+3 that is collected within this, think of it as a soap bubble. And because it's collected within this soap bubble, you're able to more precisely deliver the right doses of chemotherapy to the bone marrow. And a clinical trial was undertaken where this liposomal chemotherapy called CPX-351 was given to patients with secondary acute myeloid leukemia or therapy-related acute myeloid leukemia. And again, what you can see on the left-hand side in the survival curve is that the patients with secondary AML who got the liposomal formulation called CPX-351 did better than the patients who got 7+3 alone. So we now have a specific targeted therapy for patients who have secondary AML. So we have patients who have CD33 that we've got as targeted therapy. We have patients with FLT3 mutations who have a targeted therapy. We have patients with secondary AML for which we have a targeted therapy. You know, the complexity, which I'm happy to talk about during the question and answer session, is what if you have more than one of these things? So what if you have CD33 and you have a FLT3 mutation? Well, what should you do in that case? And that's the kind of thing that we struggle with in our practices on a day-to-day basis. Okay, probably the most exciting thing that has happened for patients with acute myeloid leukemia has been the introduction of a medication called Venetoclax. Venetoclax is a medication that targets a protein in leukemia cells called BCL2. So what is BCL2? BCL2 is a protein that lives in your cells that tells cells not to die. It keeps cells alive. Leukemia cells are very smart. They don't want to die. The whole purpose of a cancer cell is that it wants to make itself indestructible. So what it does is it produces extra copies of this BCL2 protein, which tells the cell, no matter what you throw at me, don't let me die, because I need to live forever and ever and cause disease in a human being. So Venetoclax is a BCL2 inhibitor. That is, it blocks the thing that is telling the cell to stay alive. And by blocking the thing that is telling the cell to stay alive, it causes those cells to die. When a randomized clinical trial was done, giving patients the combination of our standard therapy for older patients with AML called azacitidine or Vidasa, and combining that with this Venetoclax medication, you can see that the overall survival of the patients who got azacitidine and Venetoclax in blue was significantly better than the overall survival of the patients who got azacitidine alone. What this curve doesn't capture is something that I showed you on one of those first slides. Remember on one of those first slides, I showed you that there were all sorts of patients who all we could offer to them was supportive care. We thought they were too weak or not able to tolerate the toxicity of our active treatment. But this therapy is so effective that it is now given to almost every older patient with acute myeloid leukemia. And I have patients who have now been on this therapy, patients who I never thought 10 years ago, I never thought we would be able to cure, who have now been on this therapy. They're 85 years old, they're 90 years old, and they've been on this therapy for years at this point and are living healthy and normal lives. So this is really a dramatic revolution, the use of these drugs together, azacitidine and Venetoclax, in the treatment of patients with acute myeloid leukemia. You can also give this Venetoclax with a different medication, a different type of chemotherapy called low-dose cytarabine. We sometimes do that in patients who have previously been exposed to Vidasa, and in certain clinical situations where we think Vidasa may not be the right choice. Okay, the goal of any therapy is to cure the patient at the beginning. We never want someone to get into the situation where they have what we call relapsed and refractory AML. That is AML that has either not responded to the initial therapy or responded, then the patient ended up relapsing. Again, until about 7 years ago, we had no good treatments for patients with relapsed and refractory AML. Our only treatment option was to give the patient intensive chemotherapy again. But that changed with the introduction of targeted therapies against specific mutations that patients have with relapsed and refractory AML. This is about another FLT3 inhibitor. We already talked about midastorin. but another FLT3 inhibitor called gilteritinib. Gilteritinib is a very, very potent FLT3 inhibitor that is oral. It can be taken at home. You don't need to be in the hospital for it. And it targets that FLT3 mutation. And this was a study where it took patients with relapsed and refractory acute myeloid leukemia with a FLT3 mutation and gave them either gilteritinib or salvage chemotherapy. And of course, when we do these studies, we don't know which one is going to be better. It turns out in this study that the gilteritinib, the patients who received gilteritinib in blue, did better than the patients who received salvage chemotherapy. And therefore, for patients with relapsed and refractory acute myeloid leukemia who have a FLT3 mutation, gilteritinib, this oral targeted therapy, has really become the standard of care. We have another targeted therapy that was mentioned earlier for patients who have mutations in IDH2. So this is another mutation that people can have. And with relapsed and refractory AML, again, this is an oral therapy, very well tolerated. And for patients who have relapsed and refractory AML with an IDH2 mutation, we now give them this oral targeted therapy called enasidenib that they can take at home. And finally, we have another targeted therapy for patients with mutations in IDH1. Those patients can get a drug called ivosidenib. And for those patients with IDH1 mutations, this ivosidenib greatly improves how patients do after they are given this drug if they've got an IDH1 mutation with relapsed and refractory AML. Okay, so now here's where clinical research comes in. So one of the things we noticed at Sloan Kettering, and not just us, but others noticed, is that sometimes patients are going to have mutations not just in IDH1 and not just in IDH2, but they're also going to have mutations in FLT3. And sometimes if you have a mutation in IDH1 and you give that patient an IDH1 blocker, an IDH1 inhibitor, that patient will then develop a mutation in FLT3. So how are we going to tackle that? So we at Sloan Kettering now have a clinical trial that is about to open where we're going to be combining different targeted therapies in patients who have both IDH1 and FLT3 mutations. We'll be giving them IDH1 inhibitors and FLT3 inhibitors at the same time. The reason we do these studies is to be sure it's a safe thing to do, but we think this really offers a lot of promise to have to patients who have dual mutations. Okay. The last thing I'm going to talk about, or the second to last thing I'm going to talk about, is maintenance therapy. So maintenance therapy means as follows. It used to be in acute myeloid leukemia, we just talked about induction, which was your first round of chemotherapy, and consolidation, which was the chemotherapy you received after you went into remission. But now we talk about giving maintenance therapies after a patient has completed consolidation to prevent the patient from relapsing, okay? This is something that is very new. There have been maintenance therapies for pediatric leukemias. There have been maintenance therapies for myeloma for a long time. In some ways, there have been maintenance therapies for breast cancer, if you think about things like tamoxifen or exemestane. Those are all maintenance therapies. We've never had maintenance therapy for acute myeloid leukemia until now. And this was a randomized trial that took patients with AML that had gone into remission and completed induction and consolidation and randomized them to receive a medicine called CC486 or placebo as maintenance therapy. And what you can see in these survival curves, the top one is the most important one, is that the patients who received maintenance therapy with this drug CC486 in blue did better and lived longer than the patients who did not receive the maintenance therapy. So maintenance therapy is now something that we offer many of our patients, not all of our patients. It's a little bit complicated when it comes to transplants, but many of our patients with acute myeloid leukemia who are not having a transplant who get induction and consolidation. We also can give maintenance therapy after a stem cell transplant. So many patients with acute myeloid leukemia will have a stem cell transplant as part of their therapy. And the question is, well, let's say you had a FLT3 mutation when you were diagnosed. Is there any benefit after your transplant as putting someone on a FLT3 blocker, on a FLT3 inhibitor? This was a trial done from Germany, from a very good group in Germany that asked this question. They said, if you've got a FLT3 mutation, you go into remission, you have a transplant, does it make sense to give someone a medicine to block the FLT3 mutation, even if you don't know if it's still there, after they're done with their transplant? And the answer was, in this case, the answer was yes. You can see the patients in blue who got the FLT3 inhibitor, this one a FLT3 inhibitor called sorafenib, did better than the patients who received placebo. Okay, and finally, I want to show you one more thing. The first thing I'm going to show you is these curves here. So a second ago, I talked about how we can give IDH inhibitors for patients with relapsed and refractory acute myeloid leukemia. We just published a clinical trial showing that you can now combine IDH inhibitors with intensive induction chemotherapy for newly diagnosed acute myeloid leukemia. That's important because, as I told you, the goal is so that nobody relapses. We never want anyone to relapse. And you can see that the patients here, whether they got the IDH1 inhibitor in blue or the IDH2 inhibitor in red, they all did better than might be expected than if they hadn't received those inhibitors. The other thing I want to talk about is a very, very, very new class of compounds that I am particularly excited about. And that's a class of compounds called Menin Inhibitors. This is something that's very, very new for AML. And I think if you have the chance to read about what's going to go on at our big annual meeting, which is coming up in the middle of the early December, what you will see is that that these drugs may be very effective. So basically, this is a drug that targets patients with a different mutation called NPM1. And in this trial, and a different mutation called an MLL rearrangement. And what you can see is that in this trial, patients had a remission rate of just about 50%. So remission rates of 50% in patients with relapsed and refractory AML are really remarkable. I've personally treated many patients with this drug, and it's hard to explain. It's actually a little bit hard to explain in words how moving it is to see these patients, because we've had some patients who have been really at the end of their rope, very, 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 very ill, and we give them this medicine, and it's an oral medication. And their leukemia just kind of melts away, and they get better, and it's something that you don't really see all the time, and I think it's emblematic of the kinds of treatments that are being developed now for the patients with AML. So overall, I think the future of AML is bright. We wandered in the desert of no treatments for 40 years, and now we have multiple new drugs that are improving life for our patients. We have drugs for different mutations and different types of AML. We have extremely effective low-intensity therapy and Venetoclax and Vidaza that is safe, as well as leads to really significant improvements in survival. But we have a lot more to do. We are not going to be satisfied, and I'm not going to be satisfied until we cure everybody. You know, we have to build on the gains we have made, and that research has to be done quickly, because we can't wait another 40 years to get the improvements we've had recently, and we need to cure everyone with acute myeloid leukemia. This is my last slide. It's sort of just before I open it up to questions, really building off of my last point, I just want to make a pitch for why it's so important to participate in clinical trials. The only way we really make advances in these diseases are by doing the kinds of research where we can investigate approaches that really we think are going to help people. You know, if all the advances we've made are because people have volunteered to participate in investigational clinical studies, we don't, you know, cancer in general, only about 10% of patients with cancer go on clinical trials. If we could even get that number up to 50%, I think the ability to cure not just AML, but also all kinds of cancer really would dramatically improve. And with that, my allotted half hour, or I went over a little bit, is over. And I am happy to take any questions. I don't know if someone is going to moderate, or I should just stop talking. Now, one question though. So if you have a question, I can't, just because of the nature of what I do, I can't talk to anyone's particular specific clinical situation, but I'll try to make more general comments about leukemia.
Hi, Dr. Stein. So I know you can't speak to somebody's personal clinical status, but when you talk about clinical trials, my mom, who has relapsed refractory AML, but is only 63, we feel like the hospital she's being treated at isn't very innovative. So I've been doing whatever I can to try to get her into Sierra, which I know you're involved in at MSK. Do you know if, in these types of situations, is there anything, people can do if they're really, pushing to have a loved one involved in a clinical trial that could be beneficial?
Yeah, I mean, so it depends on the hospital so it depends on a number of things. So, if the hospital where the patient is being treated is not offering what you might want. Thank you. What you might want, it's very reasonable to get an opinion from a different doctor. I mean, I can tell you that in my practice, I know I don't have all the answers, and I welcome when patients go to get opinion. I mean, I send patients for other opinions to people I respect, and I welcome when patients go get other opinions. So I think it's very reasonable to reach out to another hospital and see, or especially another hospital where the Sierra trial might be going on, and to find out if participation in a clinical trial and their clinical trial might be an option. It's not always an option because sometimes the condition of the patient is such that they might not be eligible to participate in a clinical trial. Sometimes a clinical trial may not have spots available, but I would certainly encourage you, and especially with telemed, I would encourage you to reach out to another institution. I mean, the other thing is that, and I don't know if I speak for everyone, but most of the people that I know, like when a patient's family member gives us a call, to be very straightforward, we're always willing to talk to people. I'm not willing to give specific medical advice without having met the patient, but we're always happy to talk to people and advise them. So, I don't know exactly where you are, but if you reach out to someone at a major hospital, a leukemia expert, I'm sure they'd be happy to talk to you about it.
Well, thank you, Dr. Stein. That was such an informative presentation, and I do see some questions coming in through the chat, so I'll go ahead and read them off. There's a good one here that asks, is it possible to achieve a cure with targeted therapies, or does this still require transplant? And does cure require eliminating not just leukemia cells, but all the genetic mutations and chromosomal abnormalities in the patient's body as well?
That's a really good question. And I want to ask if the person who asked that question has done research before, because it's the questions that we struggle with. So the second question is actually easier to answer than the first question. So you don't have to eliminate all the mutations and abnormalities, because all the mutations are present only within the leukemia cells or within the bad cells. So if you can eliminate all of the bad cells, by definition, the mutations die with those cells. So it's not like there are mutations sort of floating around in other cells that you're not targeting. You're targeting the cells that have the mutations, and then those cells die and the mutations go with them. Now, the question about whether you can cure someone with targeted therapies, or does it still require a transplant, that is a tough question. I would say that we still favor transplants for patients who get targeted therapies. If they get into remission and if they can have a transplant, we still favor a patient having a transplant. Usually with these targeted therapies, about 20% of patients who go into remission will have long-term survival and possibly a cure. So I have patients, I just saw an 84-year-old woman, patient of mine, very nice older woman from New Jersey, who had a relapsed AML with an IDH1 mutation. We put her on the original clinical trial of ivosidenib, and she couldn't get a transplant because she was too old. And she's been on that drug now for 7 years. I saw her 2 weeks ago, and she's doing great. So she has achieved a functional cure. If you define cure as no reappearance of the leukemia, despite the fact that she's on a treatment, she's achieved a functional cure. However, I do think that in patients who can have a transplant, what we usually do is try to use the targeted therapy to get them to a transplant. But there are some patients who will have long-term survival and a functional cure by remaining on targeted therapies.
Great. That question was from Steve, and he followed up with a comment saying that he's a 5-year AML survivor with double cord blood transplant and is now a patient advocate.
Great.
I've talked to Steve quite a bit. He's also quite the writer. He's being modest. He's great. Let's see. I have a comment here from Jeff. He says he's 146 days post-transplant, taking 75 milligrams of midastorin a day as maintenance, been in remission since April 14th of 2020. So
that's great. And I would just say that I think this is a great example of how we're now using these targeted therapies. I mean, we didn't talk about midastorin as a maintenance therapy post-transplant, but it's a very good thing to do. And we're really using targeted therapies not only for relapse patients, but also for maintenance therapy. And I hope you're doing well. And I certainly hope you continue to do well on this treatment.
Yeah, absolutely. A question here from Nancy is asking if Vyxeos the best chemo to treat therapy-related AML. Her 19-year-old son was diagnosed with this as he received chemo last year for Hodgkin's lymphoma.
Yeah, so this is one of those caveats that I mentioned about. So I did say in the talk that that we use Vyxeos for therapy-related AML. This would be, again, I can't speak to the specific situation, but the thing is that trial with Vyxeos was only done in patients between the ages of 60 and I think 75 years old. So we sometimes think about doing something different in patients who are younger. In fact, 19-year-olds at Memorial Sloan Kettering, 19-year-olds are actually treated on our pediatric service. And believe it or not, the way pediatricians treat AML is actually a little bit different than the way adult doctors treat AML. They tend to give much more intensive chemotherapy. So I guess the answer is that I'm not sure Vyxeos is the right answer for a 19-year-old. And it really depends on a lot of the specific genetic alterations and other things to decide whether that might be the best treatment.
Yeah. Nancy says, thank you. And someone here is asking your opinion on how to push for the care team to treat a family member's personal data versus chemotherapies that I don't believe are helping.
Yeah, so it's a tough question. So let me make a couple of comments. The first comment is that many of the personalized therapies, as I showed you in the slide deck, are add-ons to traditional chemotherapy. So, in the relapse setting, we often give personalized therapies that are single agent inhibitors of specific different mutations. But in the newly diagnosed setting, we try to build on our prior successes, right? So we would never take away chemotherapy and then give something in its place. What we try to do is build on by adding stuff to the chemotherapy. What I sort of sense from the question, though, and this happens, unfortunately, I think too much, is that that there can be differences of opinion between what a patient might think and what their doctor might think. I think this is a good situation to get a second opinion. I mean, like I said earlier, I think second opinions make a lot of sense. These are tough diseases to deal with, and getting an opinion from another doctor and seeing what that other doctor says makes sense. And I can tell you, I get patients who come to me for second opinions, and it's a pretty small leukemia community, those of us who treat a lot of leukemia. So we're all kind of friends. I mean, professional colleagues, or maybe is the way to put it. So I might write to the person who sent the patient to me and say, hey, have you ever thought about this? And we're all pretty open to different ideas. So I would encourage you, or I would encourage the patient to seek a second opinion or even a third opinion from someone else. I'll just make a comment that sometimes you can overdo it though. There are some people who get like 9 opinions, and then you just get confused. I think the sweet spot is 2 to 3 opinions in my humble opinion.
Yeah, that's really good advice. There's a question here. It's probably broad and depends on a lot of factors, but somebody's asking how long maintenance therapy usually lasts.
Oh, that's such a hard one.
Yeah.
I wish we knew. We don't know. So, you know, the clinical trials that were done, in general, they didn't necessarily stop the maintenance therapy. And I'll tell you what I struggle with as a doctor. And even doctors can be a little bit irrational, and I'm a little bit irrational in this way. If I have a patient on maintenance therapy and they're not having any side effects from the maintenance therapy and they're not relapsing, even though I know it's not scientifically sound, I worry that if I stop the maintenance therapy, that something bad will happen. So in patients of mine who are doing well, who are not having side effects from maintenance therapy, I've been keeping patients on for potentially 3 or 4 years. At some point, I decide, well, you know what, I'm comfortable now that everything's going to be okay. But in the absence of side effects, and if it's not causing problems, you know, I just keep it on. And now if it's causing side effects, that's a different story, right? I mean, if you're having a side effect from a medication, then we stop the maintenance much earlier.
Yeah. A question here about booster shots, a little off topic, but you can let me know what you think. Said, had 3rd Pfizer booster on October 15th. My ALT number has spiked to 104. Does booster affect the liver?
I am going to say that I'm going to plead ignorance.
I
I actually don't know.
No worries. Just throwing it out there.
I mean, the truth is, you know, most people aren't getting their liver test numbers checked out. Well, I guess if you look at the clinical trial, what I would do is you could probably Google it and find in the clinical trial data from the original Pfizer drug, like whether it caused increases in liver tests.
Yeah. Okay. So how quickly can patients get risk stratified after diagnosis? And do general oncologists know how to personalize care, or should all patients be with an AML specialist?
Yeah, so you can be risk stratified relatively quickly. We typically it depends on the institution you're at or where this information is sent. You can typically get the information back within 1 to 3 weeks. Some of the genetic information can take longer to come back. So typically 1 to 3 weeks is the amount of time it takes to come back. The information that is needed though to make a treatment decision usually comes back within a week. It should come back within a week. You can usually hold people and wait to treat for about a week, but it usually comes back within a week. In terms of whether they should be with an AML specialist, you know, that's a hard question. I think if it's really a general oncologist who only treats 1 or 2 or 3 or 4 AML patients per year, it's probably a good idea to get an opinion at least with someone who really specializes in the treatment of AML, either a second opinion or to move to a place where they're getting specific AML therapy. There's some general oncologists who work at relatively big practices where they actually treat a lot of AML. It's kind of like, you know, so as I go back to my second opinion comment, it's always good to get a second opinion with a specialist, even if you don't end up going to that doctor. They can help guide the general oncologist. And sort of like anything in life, if you've got a lot of experience doing it, even if you're a general oncologist, you know, like you want to go to like for hernia repair, you want to go to the surgeon who does like hernia repairs every day, not the one who does like a couple a year. So it's the same thing with anything. So it's reasonable to at least get an opinion with an AML specialist, even if you don't transfer your care there.
Yeah. So we'll end on this one for the sake of time. Do only certain hospitals offer these therapies and treatments? My oncologist has not mentioned anything about treatments outside of regular therapies.
I mean, there are certain hospitals that don't, have clinical trials available or might not be as up to date with the novel therapies. I think a good question you should always ask your doctor is to say, are there any clinical trials that you think would be appropriate for my situation, either where I am now or at a different institution? And, when patients ask me that, I've usually thought about it beforehand because that's what I do, because I do clinical trials. But I think that's a good question to ask. And I think general oncologists might not think of that off the bat. So I think a good question, in addition to asking about side effects, asking about, how well is this going to work, people ask about how much is it going to cost, asking, are there any clinical trials available that you're particularly excited about, which might be good for me in this situation? I think that's an important question to ask your physician.
Yeah, absolutely. So we'll wrap up our Q&A. I think we all learned so much today, Dr. Stein. We really appreciate your time and for being here with us. We're so happy to have you help us launch this adult AML chapter today.
Yeah, happy to be here and happy to help out. And I am really excited about HealthTree. As I said earlier, this is amazing and it's really well done. So I look forward to future collaborations.
Awesome. Well, so I'd like to wrap up by mentioning that our next adult AML chapter meeting will be on November 15th at 3 p.m. Eastern. This event is going to be extremely unique in that we will be hearing from Nobel Prize winner and immunotherapy pioneer, Dr. Jim Allison. By registering, you will receive access to his documentary Breakthrough, which we encourage you to watch prior to the event and pre-submit your questions for him to answer live during the event on the 15th. The registration page for this event will be available on our website starting next week. Once it's posted, you can visit by following the link on the slide here, healthtree.org/AML/community/events. Once again, thank you to our HealthTree community for AML event sponsors, Bristol Myers Squibb, Amgen, Genentech, and AbbVie. And thank you all for helping us build a strong HealthTree community for AML. I appreciate you all and hope each of you have a great rest of your day.